literacy. As you may be aware that the United States is coming into a big phase of healthcare reform, yet another healthcare reform. The DRGs, managed care, and now we're moving to national health insurance. Much like you, we're going to be bringing in some 40 million patients, families into our healthcare system that up until now have been mainly served by their healthcare needs by just going to the emergency room, because the emergency room cannot deny, by federal law, the emergency room cannot deny care to the patient. So much like you, I believe you're having 80 million patients come into your healthcare system in the next few years. So one of the things that we've recognized is that with the level of technology that we have, in other words, the sophistication of care and equipment that the patient is receiving. For example, we have ventricular assistive devices now that are being implanted in the patient to keep their heart running, basically, that they're going home with. Can you imagine? So the patient needs to be at a level of sophistication where they can take care of that. And and also the chronic illnesses. So we have the heart disease, cancers, diabetes. These are all diseases that require the patient to have quite a level of sophistication to take care of themselves. In terms of the numbers of patients coming into the healthcare system, they can't stay in the hospital the whole time and be having care provided to them. They need to be engaged. We call this movement the patient engagement movement. Patients need to be engaged and help participate, take care of themselves. But to do that, we have a duty as professionals to make sure we give the information and that they understand. So when we talk about health literacy, what we're looking for is that the information that you're giving the patient, which is sometimes very complex, matches the skills and the ability of the patient and family. So you don't want it very lopsided. You don't want the complexity of the information up here and the skills and the ability of the patient way down here. It needs to be even out. And that's what we call a health literate patient is one where that is on an even scale. And I'd like to add there that health literacy is not the same as being non-literate. I mean, we do have a fairly high, I think in Minnesota it's about 7% of our population is considered non-literate. Of course, that has a big impact on patient education. But health literacy is different than just being non-literate or as a measure of your literacy. It can be very context specific. For example, if I'm supposed to fix my washing machine and it's broken, I don't know anything about that. So when I call the service person to come in and fix it for me, and if they give me some specific instructions, I'm going to need a very step by step because I don't understand how a washing machine works. It's totally out of my context. But if I were a diabetic and had to give myself injections, I would be very comfortable with that because that is my context. And so I think we always have to remember that our patients and families are not familiar with the world that we live in. And we have to help create that understanding for them. If you think about advancing the health literacy of your population, there are many ways that you can enter into advancing health literacy. So, for example, you have overall your culture and your society. And you can, just through how your culture approaches your policies, your governmental programs, just kind of weaving in health and making it more aware, raising that awareness. Your health system, what we've talked about today, care providers understanding health literacy and embracing it in their patients and families. We have the education system. We can certainly bring in information about health and wellness into the schools. Think of how many children have asthma. And what are your children eating in school? Can they learn about health and wellness at school? And all of this can come together and has a large impact on health and outcomes and costs in your society. Next slide. So there are numerous reports that have come out on health literacy from the national level in the United States in recent years. The Institute of Medicine in 2004 produced the report, A Prescription to End the Confusion. Also standardized medication labels. We know that lack of understanding about medication and how to take medications is one of the largest reasons why the patients are readmitted after being dismissed from the hospital. And one of the things that we realized is standardizing the labels on the medication bottle was a key component, at least a starting point. The Project on Patient Safety in 2007 produced the report, What Did the Doctor Say? It was through more subjective research, it was realized that the patient only understood, I believe the statistics are 80%, the patient understood 20% of what the doctor said, and even a percentage of that was incorrect. So if you really need to have systematic ways to check and double check if your patient understood what you're trying, the key messages you're trying to give them. In 2003, probably the gold standard was, as part of our, every 10 years in the United States, we do an assessment of literacy across the population. And in the early 2000s, they included a systematic evaluation of health literacy. And what we found out is that a majority of the population was unable to process and make decisions about where to access health care, how to take their medications, understand the healthcare system. Our healthcare system is very complex. In 2010, the Agency on Healthcare Research and Quality produced the report Health Literacy Universal Precautions Toolkit. One of the projects that I'm working on right now at Mayo Clinic is implementing this toolkit in our transplant practice. So, for example, we have patients coming into our transplant clinic that have to go through an evaluation for solid organ transplant, for example. And one of the requirements is that they have a caregiver. They must have a caregiver to go through the program. So we're looking at that dyad, the patient-caregiver dyad, trying to understand their health literacy. Because when they come in for their first week evaluation, every patient gets the same schedule, the same evaluation. And we use the phrase deer in the headlight. They end up leaving at the end of that week in total overload of information and exhaustion. And we want to try to assess the health literacy of the patients at the upfront, because we know that there are some that have much more difficulty processing the information they receive that week than others, yet we treat them all the same and put them through the same battery. So those are some of the reports that have come out on health literacy in the last 10 years or so. And I'd like to just draw your attention to thinking about how the patient might feel if they had lower health literacy and were in the healthcare environment. They often have negative feelings about their lack of health literacy, feel ashamed, and it's one of those things that when you look at a patient, you really can't tell. There's a lot of things you can see as a physician in assessing the patient, but their health literacy is something that you cannot assess until you start asking them key questions, because they have difficulty telling you. No one wants to look stupid. So they might, for example, their ability to read, they might say, oh, I forgot my glasses today, or, oh, I'll take that and give it to my wife. Other clues are that they've missed appointments. Sometimes we misinterpret this and think that they're just being non-compliant. It could be that they don't understand, their health literacy is low. They may ask a few questions. One of the exchanges that we currently have, in the old systems, do you have any questions? The provider asks, do you have any questions? The patient and family say no, and we're good to go and leave the room, and they didn't understand half of what was said. Poor adherence to medications, and difficulty completing forms. If you see in your waiting rooms when you give someone a form to fill out and they have difficulty, don't assume that often they may become angry. That's a common reaction. I don't want to fill out this form. It might be because they have low health literacy, that they're appearing to be non-compliant. So we often have our clerical staff go sit with them and walk them through the form step by step. So as you're working with patients, one of the things that we talk about and have education on is building effective communication skills. Obviously, this is very sensitive information. And so first of all, you have to, use build the trust with the patient to be able to have them divulge some of this information. And we talk about plain language. I'll give some examples of that. Slowing down and focusing on those 2 or 3 key messages in one. You hopefully will have many iterations with a patient, but what are the key messages for this iteration that you want them to take home? And then check for understanding using teach-back, and I'll explain that a little bit more in detail. Next slide. So here's an example of a plain language edit. I will say in our patient education department, our education materials are prepared for a middle school level. That's like grade 5, grade 6. And so because we want to have the majority of people be able to read and understand, because remember, for many of them, the healthcare language and world is outside of their context. It's not in their world. And we're also trying to rewrite to use words that are easily understood the first time. We want our material to be read and understood the first time. I appreciate that. If I have a medical situation that I'm not familiar with, again, because we are so specialized nowadays, I appreciate getting information that I can read and understand the first time. So here's an example. If the calorie intake is greater than calories burned, weight gain will result. A plain language edit for that might be, if you eat more calories than you use, you will gain weight. So it's taking the time to write it so it's better understood. And also, of course, using language that is more readily apparent and understood. For example, annually would be yearly, every year. Arthritis, pain in your joints. Cardiovascular, having to do with your heart. Dermatologist, skin doctor. Now, we're not saying that you don't need to use any medical terms at all, and sometimes the patient needs to understand the medical terms. But then you need to check and see if they understand. If they don't, you need to define it for them. That's a vocabulary. They need to add to their their vocabulary. I'd like to say a few words about teach-back. This is a method that we're implementing across the institution as part of that evaluation step. And so this is where you're asking patients to repeat in their own words what they need to know or do. Of course, using a non-shaming tone with open-ended questions. So I always say this is not a test of you as the patient, this is a test of me. How well did I do in explaining to you? And then check back and give additional information as necessary. So here's a schematic. So you start by explaining and educating, assess for understanding, clarify as necessary, and achieving your understanding. I always encourage various disciplines to talk about this at a clinical meeting and come up with some types of questions that would be appropriate for their clinical environment. But here's some open-ended questions. I want to make sure I explained your medications correctly. Tell me how you're going to take this medication. We covered a lot today about your, and I want to make sure that I explain things clearly. What are 3 things you will do to help control your? What are you going to do when you get home? Because that's a key point. How are you going to transition to your home environment? You feel safe here in the hospital or in the clinic, but when you get home, back to routine, how are you going to keep up with your health condition? What would you do if, this is an example, maybe a patient high risk for stroke. What are the first responder issues that they need to know if they have an incident at home? This is an interesting concept about learning from Brummer, and something to keep in mind in the educational environment in general. In terms of average retention rates, they've done some research and realized that only 5% of content is retained in a lecture format. Reading 10%, audiovisual a little more, 20%. Demonstration, meaning demonstrate back, 30%. Group discussion, when you have to start to verbalize in your own words. Remember, that's going back to the teach back. If the patient has to verbalize in their own words what they have to do, their retention is going to be much higher. Practice by doing, 75%. And then finally, that sort of novice to expert, when you're at the expert mode and you're teaching others, then your retention is the highest. Now I can tell you a little bit about patient education at some of the resources that we have at Mayo Clinic. This is a photo of we have a center for patient education where patients and families can come and get patient education on many topics at no charge. Of course, it costs us money to produce this material, but we feel so strongly about patients' understanding and patient engagement at Mayo that we offer this at no charge. So we offer classes on things like, for example, advanced directives, or how to eat a healthy diet, or how to sleep well, or how to take care of your bones and joints. Sort of wellness topics that patients and their families can come and participate and listen to these lectures. We provide consultative services, and this is actually how we keep our standard of patient education pretty high at Mayo Clinic. Clinical areas, there will be a physician and a nurse specialist, for example, assigned to work with this patient education specialist, and they develop patient education material for that practice. I talked about the classes. We have DVDs that patients can take and go home with, and pamphlets. We have a video on demand system in the hospital where patients can watch videos from their bed, and nurses and the providers can suggest and actually require that they watch some of the videos. Next slide. Next slide. Before the patient goes, while the patient's being roomed and waiting for the provider to come in, we have, all of our exam rooms have a workstation, and we have set it up so that we can play educational videos. The provider can set them up with an education video while they're waiting for the doctor, and yet still keep them behind our firewall so they can't get into our systems. It's not an easy task, apparently. That's what the technical people told me. Next slide. We also have workstations around the medical center so that during downtime, patients and families can get to a workstation, find out things about Rochester, but also look for medical information on credible sources. I think one of the things that any provider knows nowadays is that patients are out surfing the internet for information, and it's not always credible information. So one of our duties as providers is to let the patients know what are the credible resources that they can use for getting information, healthcare information. Next slide. If you've been to the Mayo Clinic, one of our hallmarks is this patient appointment guide that is your sort of itinerary for all your tests and procedures as you go through the Mayo Clinic. One thing that we've added to the guide recently, for example, this patient is having a EEG, and now we've added a QR symbol so that they can scan it and go in and bring up a video on what is an EEG, and they learn about it before they have the exam. Next slide. We also have developed in the recent years a patient portal. And the patient portal is where the patient can go in, and it's kind of their electronic environment. They can see electronic reports that their physician or provider puts out there. They can see lab results. Sometimes they get the lab results before the physician does. And that's a whole ethical topic that actually at home we've spent many hours talking about. And so this is an area where we believe we're going to be, we haven't yet, but we believe we're going to be able to post individualized education material for that patient. So in closing, just a few words about the impact. We know that limited health literacy leads to a cascade of suboptimal outcomes. I've talked about the ability to interpret health messages and taking medications. Lower health literate people are less likely to receive preventive care. And we know with chronic illness that preventive care is very important. People with low health literacy have more hospitalizations. They often are readmitted to the hospital. They use the emergency room more, and just overall have a worse health status and higher mortality rates, especially among the elderly. So you can see that it has a huge impact, both cost-wise and also on the quality of life. And that concludes my content, and so I'd be happy to address any questions you may have.
Thank you, Mrs. Behrenbeck. Is there any question from the floor? Some of this audience also from the postgraduate nursing student. Mungkin ada yang mau bertanya? Oh.
I have a question about how to get a comprehensive assessment to do patient education. In here, we know that we have nursing assessment, medical assessment, nutrition assessment, and another healthcare provider. Could you explain to us how to manage the many assessments?
Yeah.
Yes. Yes.
Thank you for your question. First of all, like my husband, I have to compliment you on your English. One of the things that we are doing is trying to learn a little Bahasa, so I'm very impressed on your English. And yes, the coordination, because you're right. You know, again, it needs the providers need to look at the comprehensive view, because I'm looking at patient education in a sort of a cross section, but I realize in working with the practice that they have the whole spectrum of care. That the nurse takes care of the whole patient. In other words, are they being assigned, we call that primary care in the United States, are they being assigned a select number of patients and then they're responsible for their comprehensive care for that shift or that period of time? Or are you set up more on a functional model where you have some nurses focusing on medication, some focusing on the assessment, some focusing on, as you know, rounding with the physician, that sort of thing. And so I think either model can work, but you want to set up the model so that it can still maintain that comprehensive view. At Mayo Clinic, we do set it up more on the primary care model, so the nurse has the comprehensive responsibility for the patients they're taking care of when they're there. And that includes, in the hospital, they are the coordinators for the patient education. And so now there may be some education that the physician, or we call the mid-level provider, is offering, but it is their responsibility to make sure that comprehensive plan has been developed and is being implemented, and that the patient has the appropriate information they need before they go home. And we are implementing some programs to follow up with the patient when they get home, at least with a phone call, and with we do some triage protocols to see those patients that are at high risk, and those patients may even get a visit at home. We're setting up some new programs to be able to do that, because we want to keep the patient in the home from a overall population management that's much less expensive. And we might, by actually going to the home, we might actually understand better what something that we didn't see in the hospital through the assessment, we might see in the home and be able to better address.
So does that answer your question, Bu Eni? Thank you. So any other questions from the floor? Saya persilakan kalau ada pertanyaan lain. Silakan Dr. Sasi.
See, there's a very nice room in your hospital, and who sits there? Who teaches the patient? Is it the nurse or doctors or both of them?
Both of them. I would say you're responsible for educating the aspects of your practice that you have accountability for. So for the physicians, the expectations is that they are keeping the patient apprised of their disease condition, so that the patient understands what illness they have, and then also what the treatment plan is, so that they understand what is going to be happening in the hospital, but also what is going to happen what they expect for the patient to comply with to keep their health when they go home. Then the nurse, a portion of that can be delegated. In other words, a lot of times we see the physician sort of giving the broad picture, and then the specific hands-on, how do I do this at home? If they're actually learning how to do wound care, if they're learning about how to take their medications, if they're learning about this battery pack, then the nurse would have specific teach back. The nurse has significant role in the hands-on how to convert this to my day-to-day life education. And as well as the dietitian, the respiratory therapist, the physical therapist, all the disciplines depending on what the situation is.
And do you reassess their health literacy after some time, like after 2 months or after 6 months? Do you still have the same level of health literacy, or do you provide offer other educational programs, something after?
That's a good
6 months?
question. There has been quite a bit of controversy in the literature about whether to really do a formal assessment of health literacy, like a little test, because again, health literacy, I think because it is somewhat tied to literacy, can be regarded, if there is shame involved in it, then the patient may put up a defense mechanism, and that's the last thing you want to have happen. So to this point, to my knowledge, even though there's been some experimental research programs, I don't believe that there are systematic efforts to assess health literacy in terms of a number quantitatively in the patient care environment. Now, but that is still very much under discussion. And I mentioned we're doing the project in the transplant center. That is one of the things that we're going to be grappling with very soon is, are we going to do a health literacy assessment? Because if we want to change and individualize the program for them based on their health literacy, we have to do some kind of assessment. But how do we present that to them, and how do we make sure they don't become overly defensive? Or those are some of the questions that we're going to be dealing with. That's a very actual question right now that is being investigated and worked out. Sure, yeah. Indirect measures, compliance and medications, readmission rates, those kinds of things, yeah.
Thank you for thoroughly explanation. I also have 2 questions for you. So the time we deal with patients, so as you noticed that some of our patients in this university hospital has problem with low socio-economic burden, and such patients often have a low literacy. So most of the time we are in the emergency setting. In the emergency unit, we face a problem to communicate with them or to give them education, to enforce them to make such a decision that we think it is an urgent decision for us to do some kind of intervention. For example, the coronary angioplasty or pericardiocentesis, and for them it looks scary. And since they have that low literacy, health literacy, so it's very difficult, and we face that some of these patients deny that kind of decision, that kind of procedure, that we think it's very important to give them better outcome, or to prevent them from mortality. So do you have a tips or suggestion for us for such communication?
Yes, the law is absolutely clear in America. No matter what that decision is, that is the law. So in other words, if you're saying, if I cannot perform the pericardiocentesis, you will die. The patient says, no, I am so scared, like you pointed out, that I'm not going to do that. Then if you perform pericardiocentesis and save his life, you have broken the law and you will be sentenced. What you need to do is you need to document carefully that you took everything that was in your power, including asking family members to help out, But if the patient is of sound mind and it is documented that he can make a decision, that's the decision that counts. That's actually the easy part. Where it gets really difficult is where a patient is in a situation where you say we are in a gray zone. I am not certain that he is under such duress that I actually don't think he is of clear mind. He is in such pain that he is confused. This is where I think integrity comes in the most. You have to... I'm an undiplomatic person, so I'm going to put the elephant in the room. There is nobody more arrogant in the world than us doctors. Because we're gods. We save lives. Actually, that's wrong. We're privileged that we are allowed to save lives. But we don't act that way. When we meet our patients, we roll in and say, I am going to tell you now what's good for you. I have no clue what's good for the patient. The patient does. This is where health literacy is very, very important. You painted the situation beautifully. A simple patient never having faced a doctor in the emergency room for the first time, and you're telling the patient, oh, I'm going to put a needle in your heart and then I'm going to take blood out and then, you could die and there could be a heart attack, but if I don't do it, you're going to die anyway, so take your pick. Okay. I really trust that doctor. Yes, they actually do. Most of my patients say, Doc, but just do it, because I know I'm not feeling well. That's actually not the best situation. There is a beautiful little statement from Mark Twain. If I would have had more time, and if I would have been smarter, I would have written a shorter and simpler letter. There's a translation for that. If I would have taken the time and if I would have spoken your language, maybe you would have understood what you're facing, and then we could be partners. One of the things I think we all have to learn is we are no longer the gods, because if we want to be the most successful, and I'm very sorry, I don't care how good all of you are, if you don't get the best outcomes for the patients, you're no good. I don't care. You may ace every exam. You may show me a certificate that says I got 100% in all of my exams. If you don't come to me and say, oh, by the way, 100% of my patients survive, you're nothing to me as a teacher. And I've been teaching for 30 years now, 25. So it is, however, very difficult, and you said it right. Speak the language of the patient. Take the time. When I started research, one of my best mentors once said, when you have a research idea, explain it to the janitor who cleans your room. If he understands what you want to do in research, you got a good project. If you don't, and he doesn't understand, you actually don't know what you're talking about. And there's some truth to that. If I cannot explain to my patient that I'm going to do this dangerous procedure, I actually really didn't do a good job. Medicine is getting more and more complicated, and it needs to be. I mean, just as my wife said, we're putting LVADs into patients right now for my patients with heart failure. It's great. We're actually leaving them in. They live with it. I have one of my patients is living for 6.5 years already, the oldest LVAD patient that exists. If he doesn't know how to change his battery every 6 hours, he's dead. So it doesn't help me to say, oh, by the way, you know, you got this thing and then you got to change the battery, and if you don't, you're going to die, but you know what I mean, and, you know, have a good life. It's worthless. So I needed to sit down with him and say, okay, you turn this cable into there, and this is actually where, as Julia pointed out, this is where the team approach, you got to trust. I trust my nurses. If my nurses don't do that, I flunk. And that means my team's no good. That means I'm no good, and that's the patient is no good. So, yeah, very tough. Very, very tough. And you have the exact same thing as we do. Maybe your illiteracy is higher. You still have the mandate to actually speak the language of the patient to make them see.
Thank you very much. Thank you. If we have a patient, a difficult patient that have a difficulty with compliance, so we also have those numbers of patients with a bad compliance. For example, if a heart failure patient is dealing with compliance, very important. If once this patient out of the hospital, do you have some system, for example, the community health care or nurse that would actually cross-check for what we have educated him? For example, the medicine that he have to take, or the time that he have to come back for control in the hospital, because we have dealt with such patient who for example just discharged from the hospital and didn't come back for an outpatient, or he didn't take a regular ACE inhibitor, for example. Thank you.
In the old system, we're going through sort of a revolution right now with our healthcare reform, and they could have a home care agency or a public health nursing agency come to their home and follow up, make sure that things were going on track. Now, with the regulatory agencies saying, if the patient is readmitted within 30 days, we're not paying you, or you're going to be, you know, deducted for that hospitalization. Now the hospitals are getting involved as well. So we are just in the process of setting up programs where we triage those patients, and based on an assessment, we maybe will put the patient into a high-risk category, and maybe every patient gets a follow-up phone call or two, and because the hospital, I mean, every patient, of course, has a dismissal summary, a dismissal letter that outlines what their course of action will be, and in the old paradigm, where the home care nursing, they would go off that letter. But, you know, sometimes there were misunderstandings even there. So the hospital really knows best what the follow-up program is for that patient. So I think we will see, we don't know yet, but I think it will be the best scenario if both of those are happening. I mean, if the patient needs to have nursing care in their home, that would be done through home care, but the hospital will also follow up and and hand off to the primary care, because that would be different than the specialist, and also follow up and on certain protocol.
Dr. Haryadi, is it correct that there are many students in here? Okay, who's student? Who's the student here in the auditorium when is not asleep? Student. Students. How many students? How many of you are students? Residents in training. Who's in training and who is a board certified something? All of us, good. Okay. So you are very, very, and Julia said it's not good to just lecture. So I'm going to ask you a question. We are going to treat a patient, and we're going to send him home with one medication that he has to take once a day. At the end of the month, so we're giving him 30 pills. What is the chance that that patient has taken the pill faithfully? Once a day, just one medication for 30 days. What's the compliance rate? Give me a number. What do you think? You sat down with the patient, you told him everything, he understood, he's motivated, you're really golden. So he comes back a month later. What is the compliance rate for one medication once a day? You got to know that. Come on. 80%. Now there is a good guy. It's 85%. You're very close. Ha! But now we're getting really, because who's just on one medication? Come on. We're now going to do 2 medications. But we're smart. We're good doctors. So we're going to say, we're just going to do this. You got to take both medications, same time. But you got to take 2 medications. What's the chance that after a month, what is his compliance rate? Since you were so good, want to take a second guess? You're wrong. 65%. Now, we're going to do this a little differently. We're going to do 2 medications. One is the digitalis. Actually, let's make it modern. We'll have a diuretic in the morning, but for some reason we got to give the angiotensin receptor blocker twice a day. So Ibupa, you're going to take it 2 tablets in the morning, 1 in the evening. What's the compliance rate? Not even. It's somewhere in the vicinity of 45%. There is your challenge. You had the perfect plan. You had it figured out. You knew it was heart failure. There was your regimen. You're golden. You left the room. You felt really good. Why in the world did the patient come back and is in heart failure? Actually, honestly, we don't know. And you know where this study was done? With medical students, and they flunked. The numbers that I just told you was a study we did in Germany with medical students, and they flunked miserably. And they're intelligent. How can that be? It's a challenge where you realize there may be challenges where you don't even think there are challenges. Always walk through the entire process with the eyes of the patient. I know you know your stuff. That's a given. But you really don't help, which is what we want to do, unless you see it through the eyes of the patient. And that is why a simple thing when I say to a patient who is on pulmonary hypertension, and I placed an intravenous pump into him with a belt where he needs to actually, with a syringe, fill his own container every day. He understands the principle. I got to pump, I got to fill it every day, or I die. If I don't have a super nurse that sits down and says, okay, this is what you do. You get your syringe ready, you get your sterile pads ready, and then here are the steps, one after the other. And you got to have somebody there who reads them to you and checks them off every 24 hours. Your success rate will drop. That patient will have complications, infections, pulmonary hypertension, stroke, PEs, you name it. If you have somebody as simple of saying, look, you gotta make sure that that belt sits properly so that there is no kink occurring. Those are the things that we as physicians never think about. But somebody's got to think about it, and if you don't have a team who thinks with you, you're not gonna succeed. And we want medicine to be more complicated. We have so many new exciting tools to help patients. But as Julia pointed out, we also need to bring our patients with us so that when they leave the door, they're comfortable and say, Doc, I'm going to be your partner in taking care of my health. Because I am not going to sit there with them at their home. Well, only if they're a really good cook, then I might consider that. But other than that, I would not, and I don't want to. That's their job. But I got to empower them that they can do that.
Give applause. Thank you very much, Dr. Beckenberg and Mrs. Beckenberg, for the outstanding motivation for us, because yeah, this problem is what we face every day, and it's very difficult to manage the time when there's about 80 outpatients with 2 cardiology trainings on duty every day. So I think time is very important for giving good education to increase their compliance, right?
Absolutely.
Yes. So is there any other comment or questions? Otherwise, we will have further discussion this afternoon. And thank you very much for both of you for the outstanding lectures and motivate us for working and give the best for the patients. And another applause for Dr. Beckenberg and Mrs. Beckenberg. Thank you very much. And ladies and gentlemen, at the last we will have Dr. Johnny Nordin from FK Hospital to have a brief presentation. So kami persilahkan Dr. Johnny.
Jadi FK Hospital, slide. Saat ini kami mengoperasikan 2 rumah sakit, yaitu di BSD dan di Pekanbaru. Total bed sekitar 500, yaitu 200 di BSD dan 300 di Pekanbaru. Kami beroperasi pada tahun 2008, tepatnya Agustus di BSD dan November di Pekanbaru. Kemudian positioning kita untuk di BSD adalah Center of Excellence untuk brain dan heart. Kemudian women and children dan juga health screening. Adapun di Pekanbaru, Center of Excellence untuk traumatology dan ophthalmology dan juga child development. Slide. Ini adalah tim dari Brain Center of Excellence. Kita bisa lihat di sini, ini adalah Dr. Setiowidi, Beliau adalah presiden dari bedah saraf Perhimpunan Bedah Saraf Indonesia, kemudian ditunjang oleh beberapa stafnya di sini, termasuk karena di sini kalau kita berbicara brain center, kita berbicara mulai dari brain, nerve, brain, spine, and nerve. Jadi ada juga dokter neurologi dan juga ortopedi dan radiologi intervensi. Berikutnya. Dan ini adalah anggota daripada Center of Excellence Heart. Kami ada beberapa dokter di sini. Jadi Center of Excellence kami dibentuk dari beberapa subspesialistik, mulai daripada elektrofisiologi, misalnya di bawah leadership Dr. Daniel Tanubudi, kemudian pediatrik kardiologi Dr. Sukman Tulus Putra, kemudian cardiac imaging Dr. Yasmin Tajudin, kemudian cardiac intervention Dr. Muhammad Yamin, PhD, kemudian cardiac surgery, bedah toraks dan kardiovaskuler, Dr. Sugisman dan Dr. Frankie. Slide. Apa yang ingin kita capai? Tentunya kami, slide. Kami di-lead oleh visi kami, yaitu kami ingin menjadi jaringan penyedia layanan kesehatan yang terdepan di Asia Pasifik. Jadi kami nggak berbicara di Indonesia tapi di Asia Pasifik. Tentu nggak ada salahnya kita men-stretch diri kita sedikit lebih kencang. Dan untuk itu kami akan memprioritaskan pelayanan kami khususnya kepada keselamatan dan kenyamanan pasien. Dan untuk itu semua infrastruktur dan resources kami alokasikan untuk keselamatan dan kenyamanan pasien. Slide. Ini mungkin tadi yang telah dibicarakan oleh Julia mengenai betapa pentingnya komunikasi dengan pasien. Jadi decision making proses itu harus benar-benar dari kedua belah pihak, bagaimana kita mengeducate dan lain sebagainya. Dan itu pun kami lakukan di EK Hospital, karena pasien kami ataupun istilahnya dokter yang ada di EK Hospital, mereka tidak terburu-buru di dalam melayani pasien. Kenapa? Karena sistem kami bukan fee for service. Jadi kami itu adalah salary base, dokter-dokter salary base, sehingga mereka bisa meluangkan waktu lebih banyak untuk mendengarkan pasien, kemudian mengajak pasien bersama-sama mengambil keputusan. Berikutnya slide. Kemudian beberapa karakteristik yang ada di EK Hospital, kita berbicara pertama mengenai integrated care with one price solution. Jadi pasien membayar satu tarif untuk pelayanan atau untuk mendapatkan pelayanan terintegrasi. Jadi misalnya saya ambil contoh pasien rawat jalan klinik spesialis datang ke EK Hospital. Mereka membayar harga tertentu, dalam kasus ini misalnya 260.000 untuk mendapatkan 2-3 rujukan spesialis. Ya. Jadi banyak pasien misalnya datang dengan sakit kepala, mendaftar di bagian neurologi, diperiksa, kemudian dirujuk ke kardiologi. Karena mungkin ada underlying factors, hypertension misalnya. Kemudian dari kardiologi mungkin dilihat di sini ada underlying factor lagi terkait dengan stres atau apa, bisa dirujuk ke bagian psikiatri. Jadi kurang lebih seperti begitu kami bekerja, yang kami sebut sebagai ICOPS. Slide. Dan ini memungkinkan karena dokter-dokter yang bekerja di EK adalah salary base. Slide. Dan karakteristik berikutnya adalah one patient, one room. Jadi kami mempunyai beberapa tipe kamar, secara total ada 6 tipe kamar untuk menjamin fleksibilitas, untuk memberikan kemudahan kepada pasien untuk memilih sesuai dengan kenyamanan mereka, mulai dari President Suite sampai dengan basic. Slide berikutnya. Di fasilitas intensive care unit, pasien juga dirawat dengan pola one patient, one room. Slide. Kemudian kami juga menerapkan integrated electronic medical record mulai saat penerimaan pasien sampai discharge. Ya, slide. Dan juga electronic medical consult dengan Mayo Clinic. Jadi ini untuk mendapatkan second opinion dan lain sebagainya. Slide. Jadi mungkin dari karakteristik yang telah saya sebutkan, jelas di situ terlihat bahwa ultimate goal kita adalah pasien. keselamatan dan kenyamanan pasien. Oleh karena itu ada kebijakan satu tarif untuk pelayanan terintegrasi, ada one patient one room, bagian daripada International Patient Safety Goals untuk mencegah infeksi nosokomial, kemudian electronic medical record, kemudian electronic medical consult. Semuanya itu untuk keselamatan dan kenyamanan pasien. Adapun achievement ataupun apa yang telah kita capai dalam 4 tahun adalah pasien yang telah kita serve itu kurang lebih 300.000 pasien setahun. Kalau berbicara atau merujuk ke angka Mayo, itu achievement kita untuk rawat jalan sekitar, berarti Mayo tadi 7.000 ya. 7.000, kita baru 15%-nya. Jadi kita ada 1.000-an sehari pasien rawat jalan untuk kedua rumah sakit. Jadi baru 15%. Mudah-mudahan dalam beberapa tahun ke depan kita sama dengan Mayo. Kemudian kita perform lebih 5.000 operasi setahun dan 15.000 health screening setahun. Adapun dari sisi klinis achievement kita misalnya untuk bayi berat badan lahir rendah 650 gram kami rawat dan survive. Kemudian cardiac resynchronization terapi pacemaker untuk kasus-kasus kardiomiopati, kemudian brain tumor removal surgery ini dilakukan oleh Dr. Setiawidi, kemudian arterial chemoembolization. Kemudian dari sisi akreditasi, jadi national accreditation itu tahun 2009 dan 2012 paripurna, kemudian JCI 2010. Jadi kalau sejawat bisa melihat di sini, kami berdiri tahun 2008, kemudian udah diakreditasi 2009. National accreditation. Kemudian kami mendapatkan international accreditation tahun 2010 setelah 2 tahun berdiri. Ini menunjukkan betapa kami berusaha di EK Hospital untuk strive for excellence, berusaha untuk benar-benar benchmark ke pelayanan internasional. Karena dengan JCI accreditation kami sudah menjadi bagian daripada komunitas rumah sakit internasional. Slide. Ini beberapa partner kami, kurang lebih 100 corporate partner. Slide. Dan terima kasih atas perhatiannya. Itulah profil singkat mengenai EK Hospital. Mungkin saya tambahkan satu lagi. Jadi kenapa kami berada di sini? Saya pikir juga EK dan UGM 3 huruf yang sama ya. Kalau di Jawa itu mungkin 3 huruf. Kami juga berharap ke depan poros ini terjalin. Mungkin EK bisa juga menjadi bagian daripada teaching hospital setelah Sarjito barangkali. Karena misalnya salah satu hal kami juga berusaha install teknologi kedokteran terkini atau penunjang kedokteran, misalnya elektrofisiologi study. Saya pikir itu sampai saat ini di Indonesia cuma ada 4 elektrofisiologi untuk koreksi aritmia, ya, kami melakukan terapi ablasi dan lain sebagainya, baru 4. Oh, di Jogja, berarti termasuk Jogja bagian dari 4. Tapi ke depan kami akan terus meningkatkan diri untuk artinya mensejajarkan diri dengan komunitas internasional. Terima kasih.
Terima kasih Dr. Johnny. So ladies and gentlemen, as the time limited, so we, on behalf of the Faculty of Medicine, so Dr. Haryadi will hand it Dr. Beckenberg and Mrs. Beckenberg, and also EK Hospital, souvenir from the Faculty of Medicine of Gajah Mada University. And a representative from EK Hospital. This faculty would also like to hand it a souvenir from Gadjah Mada University. Thank you very much. Teman-teman sejawat dokter dan hadirin sekalian, dengan demikian kuliah pada pagi hari ini kita akhiri, dan kami mengharapkan kehadiran teman-teman sejawat untuk diskusi bersama dengan Dr. Beckenberg di bagian kardiologi dan kedokteran vaskular Universitas Gadjah Mada yang terletak di Rumah Sakit Sarjito. Kemudian juga untuk mungkin nanti Ibu Beckenberg juga akan berdiskusi dengan nurse di Rumah Sakit Sarjito. So, Dr. Beckenberg and Mrs. Beckenberg, thank you very much for your outstanding lectures again, and
For giving us so much time.
thank you. And we would like to invite you to the Department of Cardiology and Vascular Medicine in the University Hospital, just across the building, this afternoon at 1 o'clock after your lunch, and we will have a thoroughly discussion about cardiology. Thank you very much.